Welcome to the third episode of Carilion Clinic's Antimicrobial Stewardship podcast. We plan to use this series to discuss topical infectious diseases issues. This series is being made by medical professionals for medical professionals. I am this episode's host, Nathan Everson, a board-certified infectious diseases pharmacist here at Carilion Clinic. I'm here today with Dr. Josh Holley and Dr. Lubna Wani, and I'm going to let them introduce themselves. So, Dr. Holley, I'll let you go first.
My name is Dr. Joshua Holley. I am a practicing otolaryngologist with Carilion Clinic. I am based at Carilion Clinic's New River Valley Medical Center location, and I've been practicing ENT as a board-certified otolaryngologist for approximately 15 years.
Hi, everybody. My name is Lubna Wani. I'm an internal medicine physician. I have been practicing for over 20 years, and I do primary care. That's my main focus. I work for Carilion Clinic, and my clinic is located at Riverside 3.
Awesome. I appreciate both you guys for joining us here today. We're going to center our conversation today around some of our most commonly encountered ENT-related infections, kind of including sinusitis, otitis media, strep pharyngitis. We've got a series of questions for our guests, and we're going to use that to share insights from both their practices, as well as kind of any updates to current treatment paradigms that we have right now. So I'm going to kind of launch into the first question here to get us started. And we're going to open up with probably one of our most common encountered ENT infections would be pharyngitis. Although commonly viral in pathology, we see a ton of antibiotic use. Can you both give me some insights on what you, in your assessment of the current best practices are in diagnosing a pathogen in pharyngitis and making that decision of whether or not to treat? And I will turn it over to Dr. Holley to get us started with this question.
So I'll start the conversation kind of from a surgical perspective. Clearly, one of the most common procedures performed in the United States on children under general anesthesia is ear tubes and tonsillectomy being the second most common. And so from an ENT perspective, we get a lot of referrals for patients for recurrent strep pharyngitis, recurrent sore throats. And so really where I base a lot of my practice is I try to be as evidence-based as possible. And so I really lean heavily on clinical practice guidelines, primarily from the Infectious Disease Society of America, in addition to the clinical practice guideline on tonsillectomy from the American Academy of Otolaryngology. Typically, we will see mainly kids and even adults who have been seen in various primary care environments, whether it's urgent care or primary care, that are typically having 1 or 2 days of symptoms with or without point of care testing that will still lead to antibiotic prescriptions. Often I spend a lot of time in my practice trying to counsel and educate our patients and their parents on appropriate antibiotic and medical therapy and even non-antibiotic therapy that can improve symptomatology, is try to make these patients feel better even if an antibiotic is not indicated. I do think from a public health perspective, one of the things we've certainly seen in the schools is that often the schools will require a medical visit even after a single missed day of school. And I think that leads to some issues where you just have more encounters with primary care where they may not have really been indicated. The parents may have been comfortable taking care of those kids at home, but the school needs a doctor's note, and it seems like the more interaction that a patient has with the medical system, clearly the higher the risk of receiving an antibiotic, whether indicated or not indicated. And so I think, really if you look at clinical practice guidelines, specifically from the Infectious Disease Society of America, they're pretty clear on who they recommend testing. One of the interesting things is they recommend against testing in children less than 3 for strep throat. In those children, strep throat is less common. Complications of strep throat are less common. And I'll get referrals for a 3-year-old for recurrent strep, which means that child's been treated sometimes up to 7 times with antibiotics at age 3. And then they're asking me for a surgical decision on that child. From a surgery perspective, classic indications for tonsillectomy as it relates to this topic are 7 infections in a year, 5 infections for 2 years in a row, or 3 infections for 3 years in a row. And this was a study that was done in the mid-'80s at Children's Hospital of Philadelphia. And even in that study, children who were severely infected that underwent tonsillectomy showed no more than 1 year of benefit after surgical intervention. So this indication for surgery has certainly waned over the last 2 decades. Matter of fact, only probably 10% of tonsillectomies in the United States at this point in time are performed for a recurrent infectious indication. Matter of fact, the Infectious Disease Society of America recommends against tonsillectomy solely for the reason of reducing strep. If there's other things involved, then there may be other indications. But the most common indication for tonsillectomy nowadays is sleep apnea in children. And so, still trying to kind of promulgate that information into the mainstream, to really not provide an expectation to a parent that their child needs a surgery to reduce these symptoms when in fact it may not provide, or it really will not provide, long-term benefit really in any patient.
Appreciate your thoughts and your opinions on that. I'd like to turn it over to Dr. Wani to kind of hear what your thoughts are in practice on kind of best practices in pharyngitis.
Thank you, Nathan. Thank you, Dr. Holley. That was really a good review. I will focus on adults because that is my main, that's whom I see most of the time. We know pharyngitis in primary care, there are millions of visits every year in the United States for sore throat. So I just want to emphasize before I start that contrary to the belief of many physicians, that acquiring an antibiotic is the most important priority for patients. Majority of those patients who seek a visit to the primary care for sore throat are just wanting some advice on prognosis and symptom management. As sore throat is very painful, that is their main concern. And we have done multiple studies on this and found that almost more than 80% of the patients, they are not seeking antibiotics. It's just about 30%, and they just need guidance and pain relief. So I think that is very important for all of us primary care physicians to understand. Also, we know that pharyngitis most commonly in adults, about almost 80 to 90% is viral in nature. And for the viral pharyngitis that we see, patients needing pain relief, non-steroidal anti-inflammatory medications can be used. Salt gargles can be used. We do use Tylenol in patients who can't tolerate NSAIDs. And we have to tell the patients that supportive care is all that's indicated. And most of the symptoms usually resolve in 3 to 5 days. And for me in primary care, this is easy to do now because of the My Chart. We encourage our patients to message us if they have further concerns or if they get worse. The second, bacterial, as Dr. Holley touched on it, it is mainly concern strep throat in children. In adults, it's very rare. And clinically, for physicians to diagnose this is very easy if the patient meets the center criteria, which is fever, tonsillar exudates, absence of cough, and anterior cervical lymphadenopathy. If a patient meets these criteria, when I see them in the clinic, it's very easy to diagnose them with strep throat. And of course, for strep pharyngitis, antibiotics are indicated because we want to decrease the incidence of rheumatic fever and rheumatic heart disease, which we rarely see in adults now because we have been good about treating this. If the diagnostic criteria are not very clear, then doing a rapid strep test, which we can do in the clinic, is really easy, and it is quite sensitive. Of course, throat culture is pretty sensitive. That can be done too if we have any concerns. For the adults, we recommend 10 days of antibiotics, penicillin, like amoxicillin. The other things to keep in mind when we see patients with pharyngitis is infectious mononucleosis, again, which is a disease of young adults. Again, it's self-limited. There is no treatment, and supportive care is all that's needed. We do have blood tests for that to diagnose that, so that can be diagnosed as it has some similar features like strep pharyngitis. The other thing to keep in mind in sexually active young adults is gonorrhea and chlamydia. Those are two things we can see with strep pharyngitis. Very important to diagnose these and treat this. Of course, with the COVID now, that has been surging. Pharyngitis has been a very common symptom, and I cannot tell you how many calls we get every day about patients having sore throat. And then when we ask them to test, they are COVID positive. So keeping that in mind is very important too. Thank you.
Yeah, I appreciate your thoughts on kind of your experience with adults in primary care. I love that you also brought up chlamydia and gonorrhea. I know that that's an area where at least most practices are only doing urine testing for chlamydia and gonorrhea. Even some of our urgent cares, we've kind of struggled to get some alternate site testing done, or is not done regularly. So making sure that the throat pharyngeal swabs are done. I see in our ID clinic frequently our GC tests are not positive in urine and are positive in either pharyngeal or rectal samples, is where it's most likely to be positive in our experience. So um, the I guess my follow-up question for you guys, and feel free to jump in whoever wants. I think that some of our conversations, Dr. Holley, is that there probably is a little bit of maybe either over testing or over treatment for like strep pharyngitis. The criteria that Dr. Wani was talking about, do we feel that like that is a criteria that gets used a lot, or is maybe needs to be better rolled out and better emphasized and kind of reduce maybe excess, rapid strep tests?
Well, and I think one of the controversies with the Centaur score is even somebody who has, 4 or 5 points, whatever the highest score you can have, is that they still really only have a 50% risk of strep, even with a center positive screening. And so, I think in those cases, I mean, the struggle is, and I don't know, and you and I talked about this a little bit, Nathan, are there protocols built into, say, velocity care or something where these patients come in with certain symptoms and, they automatically get a COVID strep RSV? Some of these are kind of just built in protocols or policies that we may not necessarily in our institution have absolute control over. I certainly think that, if you risk stratify a patient based on their presenting symptoms, their physical exam findings, and as Dr. Wani alluded to, understanding that the true risk of strep throat in an adult patient is probably 15% or less, I find it kind of interesting that we're going to test everybody, even though the risk is really that low. As she alluded to, talking about rheumatic fever, rheumatic heart disease, the numbers and the incidence of those conditions were on the decline even before the advent of modern antibiotics. And so I think a lot of the things that we tend to be, quote, scared about are actually very, very rare. A lot of the data that looked at those were in studies in the 50s. Those studies have really never been reproduced in a kind of normal environment or a more modern environment. And so, I question even if the aggressive management of a lot of these conditions and the way that we currently treat them are really indicated. And again, there's a number of medical professionals that kind of question the dogma or the pragmatism that we've kind of went to this point, because of the vast majority of these bacteria and even the viruses have evolved along with humans and the immune system, and an immunocompetent, otherwise healthy person is probably not going to have an adverse side effect or risk from even a mild bacterial infection. I often joke with my nurses that if we hung out at a Walmart with a box of rapid strep tests, I bet you we would find a number of positive patients, both symptomatic and asymptomatic, in the community. And I think that kind of brings up another topic as far as strep carrier status, or even, how long does point of care testing stay positive after an acute episode? If you look at data on rapid antigen testing, it can stay positive up to 3 months in certain patients. And so these patients that come into urgent care, primary care, month after month after month and continue to have positive tests, I think that's really where culture may be beneficial, because as we saw with COVID, people can stay COVID positive from a genetic material perspective for months and months and months, even though they're no longer infectious and are not harboring pathologic bacteria. And so, and those are clinical dilemmas with when you're trying to determine what the most appropriate therapy is. You certainly don't want to miss something and let it go to something worse. But a lot of these conditions, it's just not going to happen, right? And I don't necessarily think it doesn't happen because we treat so much. I just think because there's plenty of people, I think, every day that have strep throat that never go see a doctor. And if these complications were really prevalent, we would see more of those happen. And so I think some of it's just looking at the community history of these diseases.
I just wanted to add that in our adult setting, when we mostly see patients who come in with concerns of strep pharyngitis, it's parents whose children have been diagnosed with pharyngitis. So, we evaluate them. If they clinically meet the criteria, of course, then we treat them. But again, as Dr. Holley said, doing a strep culture, if we don't clinically feel that they have strep pharyngitis, is what we do.
Yeah, I really appreciate your guys' insight there. I think that there's probably some folks think that, particularly from the community, is that like a strep throat is you go in, you get a swab, and you get treatment, and that's how it works. And I think I'm glad you guys are talking about there's quite a bit more nuance to getting to the point of just doing a test and kind of moving away from treating a test result and treating an actual condition. Um, so we do see folks who have persistent pharyngitis symptoms despite appropriate management. One of my favorite like infectious disease facts is the fact that like strep pyogenes has just never really developed much resistance to penicillins, whereas we see that with a lot of the other streptococcal species. So generally knowing it's 100% of the time, a penicillin is going to treat it, we still see Z-Paks getting used, which have, in our case, sometimes up to like 30-40% resistance in our area for macrolides and strep pyogenes. But when you have these patients who show up and they have persistent pharyngitis and started to become a little more complicated, what are your guys' next steps in terms of kind of continuing to evaluate that and trying to avoid just overtreatment? I'll start with you, Dr. Holley.
So this is a common topic in my office. Clearly, when does acute sore throat become kind of more chronic, and certainly the differential diagnosis at that point becomes much more broad. Um, you know, I think, a patient that's had 4 weeks of symptoms, 6 weeks of symptoms, I think that you can pretty much take an infectious etiology off the table in most of those patients. I think thinking about things like GC, chlamydia, mono, some of these other more chronic infectious conditions. As a matter of fact, we have the ability to do GC swabs in our office. We actually we do that not uncommonly. But I start thinking about non-infectious causes of chronic sore throat. Allergies can certainly do it. I think in my business, reflux, in what we call laryngopharyngeal reflux and ENT, is a common cause. And these patients can have acute exacerbations. I think, a lot of patients with chronic illness suspect that those symptoms are always going to be stable, but they often wax and wane. And so these patients will have kind of a chronic low grade reflux sore throat, and then it gets acutely worse. And whether that's a viral exacerbation or whatnot. And so and then even thinking out about other things like Bartonella, cat scratch, looking at lymph nodes. And then worst case in my office is cancer, right? So patients with throat cancer will present, unfortunately, with months of sore throat after failing multiple courses of antibiotics, going, shots of Rocephin, Ceftonir, everything. And a good physical exam is really the tenet of good medicine. And so looking in their throat, and I had an ER call last night about a patient that fit this criterion. You look in there and, the tonsil is ulcerative and they've got big lymph nodes. And this is a patient that had a malignancy that was being treated as an infectious sore throat for the last several months. And so really, I think establishing a good differential diagnosis. I think too often we tend to kind of anchor on the first thing that comes to our mind. And even in a patient with a week or two of symptoms, I think you still have to think about those other things in the back of your mind. Try to rule them out with an initial physical exam. Treat it, empirically or based on test results. And if they don't get better, instead of thinking that that's antibiotic failure, as you alluded to, is what else could it be? Because the definition of insanity is doing the same thing over and over again, expecting a different outcome. And I see a lot of those patients that have been on 4 or 5 courses of antibiotics. I've seen patients with C. diff, and there was really no infectious etiology or mechanism to their symptoms to begin with.
Thank you, Dr. Holley. I really don't have much to add, Dr. Holley. talked about all the things, just a couple of things. As he said, in our primary care setting, again, if a smoker comes in who has had worrisome sore throat symptoms for, a week, 2 week, 3 week, that really worries me. And getting them to an ENT specialist to check for oropharyngeal cancer should be really top of our mind, because those patients are very high risk for that. And I think one thing that we do often miss too is HIV testing, because HIV can present as, chronic sore throat. So those are the two things I just had to add. And again, if we have younger people, again, as Dr. Holley alluded, again, thinking about STDs is important too, and testing for, GC and chlamydia. Thank you.
Yeah, more HIV testing is always music to my ears. And I know that I've seen plenty of new diagnoses where, thrush or sore throat was their main complaint to start off with. So I think that's an excellent point. And I think that so it sounds like, kind of in summary, that, where most of the pathogens from a bacterial standpoint that you would treat in pharyngitis should be pretty receptive, or should be pretty, susceptible to antibiotics that we use. And so after one or two courses of antibiotics and pharyngitis is still sticking around, safe to say that the options for diagnosis really kind of explode at that point in time, and really should be focused maybe away from more of an infectious etiology. Would you say that's kind of a safe statement?
Absolutely.
Absolutely, yes.
Awesome. We'll move on to kind of a new topic, a little bit away from pharyngitis. So, otitis media is one of the most common causes of antibiotic use in pediatrics. Though most common in peds, it's definitely a concern in adults as well. There are some well-documented mechanisms to help reduce antibiotic prescribing. We do watch and wait some places, delayed prescribing. The CDC has a lot of information on some of these different approaches. But from a diagnostic perspective, what would you say are the current best practices in determining true otitis media? And what is your thoughts about if there is a problem with overdiagnosis? And I'll start with Dr. Wani this time, and some of your thoughts here.
Oh, thank you, Nathan. So, in adults, otitis media is pretty rare. So, it is not a condition we see that often, and that, pneumococcal vaccines have decreased the incidence. We know strep pneumo, H flu can cause otitis media. In adults, making a correct diagnosis of otitis media, I think, is very important. And we should not confuse it with otitis externa, which is common in the adults and can be treated with local antibiotic drops. Also keeping in mind that adults can have just, swimmers there. They can have pseudomonas infection, which is, again, otitis externa, not media. But if I diagnose a patient with otitis media, we are required to treat it with antibiotics because we know it's rare. We usually do augmentin for 5 to 7 days. The pain control, again, is important. If these patients have a lot of pain, I do use steroid drops sometimes. And I know Dr. Holley will tell me we have to make sure that they don't have a perforation, because steroids are toxic to the inner ear. So just making sure they don't have a perforation, we can use that for symptomatic relief. And of course, NSAIDs, Tylenol.
Yeah, I'll turn it over to kind of what you see in your practice, because I imagine you see some of the more complex otitis media cases, or the repeat situation. So, what are kind of your thoughts on what you see?
Well, I mean, I think starting from the beginning, that you understand that 90% of otitis media occurs in children between the ages of 6 months and 2 years old, and it's secondary to eustachian tube uh, anatomy, as well as a lack of immunity, basically. And so these kids experience a lot of upper respiratory tract infections. Children who are exposed to secondhand smoke, they have a higher incidence of otitis media. And so these children typically present with what starts as a viral infection, which turns into an ear infection. Diagnostically, and I think this is the challenging thing. I know if you go to an ENT office, we have a number of tools to aid in accuracy of diagnosis. We have good otoscopes, bright lights. We have pneumatic otoscopy. I would tell you that really diagnosing any otopathology without a pneumatic otoscope really limits your diagnostic accuracy. We have tools like tympanometry, which can measure tympanic membrane compliance and middle ear pressure. And so we get a lot better exam. I can tell you that when I'm teaching medical students, oftentimes I'll see them grab the smallest ear speculum to look in an ear, and you'll rarely see an ENT doctor do that. Typically, we grab the biggest speculum to look in there so that we can see everything we need to see. Often young children, they're hard to examine. They're upset. They move all over the place. They've got small ear canals. And a lot of times, again, I think that those antibiotic prescriptions they're just in case prescriptions. We don't get a good exam. And this is really a place where they're really looking at AI in the diagnostic strategy is in basically having a camera otoscope, and then the computer could run the images against millions of images almost instantaneously to look for signs of infection. And I think it's important to remember with otitis media in both adults and children, when you're doing an exam, you're looking at the middle ear. You're not looking at the eardrum. You're trying to look through the eardrum to the middle ear. And acute otitis media is a purulent middle ear effusion. So you should see pus behind the eardrum. The eardrum should be bulging and red. Anything that is not that is not otitis media. So understanding, because I'll often have patients say, well, they told me it was a quote bad ear infection. Well, there's just an ear infection and there's not an ear infection. There's really no graduation of the severity of the condition. So if you're not seeing a bulging pus-filled middle ear, that is not otitis media. Anything that is not that does not require antibiotic therapy. And so again, I see when I'm looking at referral notes, I see dull. People mention the light reflex, which I'll tell you to ENT doctors is not important. That finding does not mean anything. A middle ear effusion that is not purulent does not require antibiotic therapy. So an adult or child after an acute respiratory illness may have fluid behind their eardrum, and if it's not infected, it doesn't need antibiotics. Typically, even after a case of acute otitis media, it takes between 1 and 3 months for the fluid to go away. And so I think a lot of times non-infected fluid gets treated with antibiotics. Often in my adult patients that have a middle ear effusion, they will present with hearing loss, not pain. A non-infected effusion typically doesn't hurt. And so I think diagnostically, it's getting a good look. It's having a pneumatic otoscope. I would tell you, if you hand an otoscope to an ENT doctor that doesn't have a bulb on it, we really don't know what to do with it. But you rarely see those tools used outside of otolaryngology. And so when I'm teaching medical students, I really try to stress, A, being able to tell the difference between a normal and an abnormal eardrum, and then if it's abnormal, is it infected or not? And so, I think that's a struggle. I think then when you go to adults, so only 1% of middle ear infections happen after age 10. So if you have an adult patient coming in with ear pain, there's 7 different nerves that go to the ear. There's a lot of overlap. You have nerves. It's the trigeminal nerve. It's cervical nerve rootlets, odontogenic trigeminal nerve. So understand that a middle ear infection, the patient will have to have hearing loss. They'll have conductive hearing loss. If they have fluid, they have to have hearing loss. So a patient with ear pain without hearing loss doesn't have an ear infection without even looking. And so that's a really, when I'm evaluating an adult patient for ear pain, because they come to me for quote ear infections, but in fact their main symptom is pain. My first question is, how is your hearing? And if they say normal, then I pretty much know what I'm going to find when I look. And so back to our sore throat and thinking about alternative diagnoses for patients with chronic symptoms. In an adult patient with ear pain, I think you really have to have a broader differential than otitis media from the beginning.
I guess I'll hazard to kind of guess that the approach for managing otitis media and pharyngitis probably have some similar overlap in terms of generally the things causing a relatively uncomplicated otitis media should be strep pneumo, upper respiratory pathogens that all are pretty antibiotic susceptible. There are parts of the country where strep pneumo has elevated MICs to penicillin, and you want to use high dose amoxicillin. That's usually a best practice. And we definitely see some complicated cases that maybe we share between ID and you, where we have maybe a tube and it's been draining for a year and it's growing some really gnarly things, but that's not a typical, situation. So, would you kind of advise, Dr. Holley, that you might give to folks who are, on their second or third attempt at treating otitis media, nothing's getting better, like that should be focusing more on expanding the diagnosis opportunities as opposed to changing treatment at that point?
It's a tough question. without looking at the patient, right? Again, I've seen a lot of patients that have, quote, treatment failures, but when we examine them in the office, their ear exam is normal, right? So back to what I was saying about, expanding the differential, you know, indications for tympanostomy tubes, and we'll just touch on it just for a second, because again, having the surgery part of this is classically 4 ear infections in a year, 3 and 6 months, or more importantly, chronic effusion, so fluid in both ears for more than 3 months or one ear for more than 6 months. Now, the clinical practice guidelines stipulate that when during a surgical consultation, we should see something abnormal. If I'm looking at normal ears during a surgical consultation, those children haven't been shown to benefit from tympanostomy tube placement. And so I think it's important to understand the natural timeline of what happens after an ear infection. So most of these children will present with acute symptoms, ear pain, fever, like you would see with anything. And on exam, they have a purulent middle ear effusion. Well, if you look at that ear again in a month, 70% of children will still have an effusion. Now, again, I think a lot of times when the primary care, they look at that and they say, oh, well, it's an infection that didn't go away, when in fact, that's just sterile effusion that's going to take some time to clear. At 2 months, approximately 40% of children will still have an effusion. And at 3 months, only 10% of children will still have an effusion. So I think sometimes we pigeonhole ourselves because we see these children acutely ill with an ear infection. We say, well, hey, come back in a month and let's make sure it looks better. Well, only 30% of children are going to have a normal exam at 1 month. And so, again, I think sometimes we're treating a non-infected middle ear effusion with antibiotics and saying it's not clearing when, in fact, the infection truly did clear. It's just the fluid that takes time to go away.
Yeah, that's wonderful insight. I mean, we see the same kind of problem. Like C. diff tests would be another classic one where you can have a positive C. diff PCR for ages after an episode, and you can have messed up GI tract for quite a while after a course too, where a lot of times folks get retreated. So I think that component of how long are you expecting the exam to be abnormal and or testing to be abnormal is a really important part of incorporating into treatment assessment and response to treatment. So I appreciate both your guys' thoughts on that. We recently got a draft of our outpatient antimicrobial stewardship dashboard, and we're able to look at prescribing across all 200 plus of our practices. And not surprisingly, we saw the number one indication for antibiotics, and about 20% of all antibiotic prescriptions was sinusitis. And at this point, I feel like who hasn't had sinusitis, or at least thought they've had sinusitis? We know patients usually are already convinced that they need an antibiotic for sinusitis. They've had it for a while and are convinced it's bacterial. And so I feel like this is definitely probably one of the more challenging disease states, particularly for some of our urgent cares where they don't really have an established relationship with the patient. They show up, they give them this history, they want something now because they feel horrible. And so I guess, from both of your perspectives, what are some tools for providers during that diagnosis of sinusitis to help rule out situations that really don't need an antibiotic? And I'll start with you, Dr. Holley.
So I think the important thing with sinusitis, first of all, is understanding that 98% of acute rhinosinusitis is viral. And if you were to look at a graph of symptoms over time, most people's symptoms peak around day 5 to 7. Maybe a little bit sooner, maybe day 3, but really it takes 10 to 14 days to see a significant reduction in severe symptoms. And typically the nasal congestion, if you look at guidelines from our academy about the diagnosis of sinusitis, really what they require is nasal congestion and discolored nasal drainage. Now, a lot of people, they get hooked around what color stuff is coming out of their nose or they're coughing up. We know that's been well studied. There's really no correlation between color of secretions and whether it's bacterial or viral. The other thing people talk about is, the height of the fever. A high fever must be bacterial and a low fever is not. That is not true either. And so, for me, the first thing is the patient can't diagnose themselves. And what I mean by that is the patient can't come in and say, hey, I have a sinus infection. They can, when a patient tells me that, my next question is, well, tell me what's going on. What are your symptoms, right? Because a frontal headache without nasal congestion is not a sinus infection, right? And so, and just touching on that for a second. So Mayo Clinic, 2007, took 100 patients off the street that said they had sinus problems. And they worked them up, scopes, imaging, exams. And what they found was 3 of those patients had anything wrong with their sinuses. The vast majority of people had migraine. And because migraine affects the trigeminal nerve, which goes to the sinuses and the nose, those patients not only just have headache, but they have autonomic symptoms. They have congestion, and um, they have rhinorrhea, and so some of these things. And so what you'll see in an ENT practice is only about 5% of the patients that are referred to us for, quote, sinus problems actually have sinus problems. Convincing patients that just because their nose is stuffy, so you can have a stuffy nose and your sinuses are fine. Their rhinitis and sinusitis are kind of 2 overlapping diagnoses, but just because your nose is stuffy, it doesn't mean you have a sinus infection. So, and just because you're not going to treat them with antibiotics doesn't mean you don't have to treat them. There's a number of conservative and supportive therapies that have been well proven to help patients with acute viral rhinosinusitis, nasal irrigations, nasal steroid sprays. Um, I if you hung out with me in my office, I almost never prescribe antibiotics. Almost never anything that I see really requires an antibiotic. However, I probably overuse prednisone. Much of these in patients that don't have contraindications. I'm not treating poorly controlled diabetes or those kind of things with prednisone, but a lot of these are acute inflammatory conditions, and the patient just wants to feel better. And so, telling them that an antibiotic is probably not indicated, but we can do things to make you feel better. I think it's important to provide that value as well.
Yeah, I appreciate your insight there. Anything from your perspective, Dr. Wani? I'm sure you guys see plenty of folks coming into their visits with sinus problems, and what's kind of been your experience for handling those situations?
Sure. Thank you. Thank you, Dr. Holley. That there are so many good learning points. I'm learning so much today too. So we see sinusitis a lot. And as Dr. Holley said, the patients are convinced they have it and they come in wanting an antibiotic most of the times for sinusitis. We know that, we try to tell our patients after we examine them and make sure there's nothing else going on, that sinus symptoms are mostly viral and they will resolve on their own between up to 7 days. It might take 7 to 10 days. So just reassuring and telling the patients to do supportive care. Like Dr. Holley said, we use a lot of nasal steroids, saline irrigation, neti pot. We tell them to do that. And again, as I said, the MyChart has made things better because patients can communicate with us. So they're not disappointed that they're coming to a doctor's visit and now they didn't get an antibiotic. So we tell them to let us know how they're doing. We usually treat persistent symptoms if they're over 10 days. I don't know if Dr. Holley will agree with that, but that is an indication for them to be treated. If the patient has very severe symptoms that even up to 4 days, like they have high fever, severe facial pain, purulent nasal discharge, we tend to try and treat them for that. If they've had 7 days of upper viral upper respiratory infection, and now they have a sinus infection, which we call double sickening, that is again indication to do give them antibiotics. Again, as you said, Nathan, we still love our penicillin and we use augmentin a lot. 5 to 7 days is usually good. I see, in urgent cares, they get prescriptions for 10 days. So that is really too much. We should keep it 5 to 7 days. And then, we can try doxycycline or fluoroquinones. We do not use Bactrim, cephalosporin, or macrolides because, is that right, Nathan? We have almost 30% resistance to those antibiotics with strep pneumo. And again, if it is recurrent sinusitis, they have multiple episodes in a year, very severe, we will have them see Dr. Holley. I also stress here with the patients that smoking cessation is very important because many smokers come in and they have all this sinus, or I have a sinus infection. Smoking can do that. So please give up smoking and your symptoms will improve.
Yeah, I appreciate your thoughts. I think that it's certainly a very common disease state. One thing that we are trying to do to kind of meet some of that patient need, because I can understand how frustrating it must be for a patient to roll up into an office and not feeling well, and And then at the end of the day, you're like, this has only been 5 days in. This is looking more like a viral situation. That can be, they paid for a copay. They made time. I can understand why that'd be frustrating to like walk away with essentially like just wait it out. One thing that we are trialing right now is in several of our velocity cares, we're doing symptom relief packs. So it includes nasal saline, tissues, lozenges. We also do some acetaminophen in it as well, for like a day or two's worth of acetaminophen, which is a new addition we just put in. And so we're hoping to see some response to that, whereas they're only given out when a patient antibiotics aren't indicated as an alternative. Like we're investing in the patient's symptom relief, which hopefully after a day or two of good symptom management, the patient should hopefully feel better and not then need antibiotics. So I think that some of that is managing patient expectations and also making them feel empowered to leave with action items. Something else we do is we have these symptom relief prescriptions that are available on our internet hub and what can be ordered from for your clinic as well. But they allow a provider to kind of go through and check what the symptoms are, how long they expect them to last, what would be over the counter and ancillary symptom relief measures, and then when to kind of call back if there's not an issue. And we've gotten some pretty good response from those prescriptions, because that again kind of creates education as well as gives the patient something that they can walk away with a plan of what to do. In your experience, are there any other kind of tips or tools that you have in terms of managing patient expectations for antibiotics?
Well, from my perspective, and I think what we tend to forget, I think patient education piece is the most important, right? And so we talk about these conservative or supportive tools, but I think all too often we kind of gloss over those things. We're like, oh, just get a sinus rinse or just get a nasal steroid spray. And I think when it comes to patient compliance, you have to get patient buy-in. And so I think really explaining, one of the classic analogies that I use a lot of analogies with my patients. And so, I'll basically ask them if they've ever had a pimple, and most people have. And you say, well, what did you do for that? And they look at me kind of quizzically, and I say, well, you took an antibiotic, right? And they're like, of course I didn't take an antibiotic for a pimple. And so you pop it. And so really, with acute sinusitis, the problem is swelling, right? And the sinuses are blocked. And so antibiotics do nothing for swelling, right? So they only kill bacteria. And if there's not bacteria, then all they do is kill your gut bacteria and cause diarrhea. So really convincing them. So if you look at studies on antibiotics versus hypertonic saline nasal irrigation, so most of the studies on nasal irrigation are look at hypertonic saline. So if they get a Neomed rinse bottle, it's 2 packets instead of 1, is telling them like, this is getting all the stuff out of your nose. This is cleaning the snot. This is really what's going to help you breathe better. And doing this really will help, instead of just saying, no, you don't need an antibiotic, do these things, but really convincing them that it's the right thing to do, that this is really going to make you feel better. And to Dr. Wani's, the smoking, I have a lot of conversations. A lot of what I see, especially my adult patients, are sequelae of smoking, and telling people that, smoking paralyzes the cilia. The tiny hair cells in your nose that are responsible for moving mucus don't work in smokers, and 70% of smokers have chronic sinusitis. And so you need to restore normal nasal hygiene. How is the mucus going to move if the cilia don't work? And so, especially in smokers with chronic sinus problems, because if you look at surgical outcomes in sinus surgery on smokers, the outcomes are terrible. You're not fixing the problem. You're just making small holes bigger. And so convincing them that a nasal irrigation in a smoker is really important, because we're trying to restore some normal nasal function, because that's what leads to sinusitis, right? Swelling, stasis, drop in O2, that's what allows bacteria to grow. And so by allowing oxygenation, allowing flow, mucus flow. And so we have samples of nasal rinses here in our office, and almost every patient gets one because it's very effective. The nasal steroids are very effective. And so, to Dr. Wani's point of kind of these recurrent symptoms, in patients that come into urgent care once a month with a sinus infection, what I would tell you, those patients probably have migraine. If a patient has a quote sinus infection and dizziness, that's probably a migraine. Really, sinus infection shouldn't cause dizziness. And so telltale tools, a lot of times what I'll also see is when I ask these patients about their symptoms, their symptoms they don't have nasal symptoms. They're like, well, no, my nose is not stuffy. Sense of smell is really sensitive. If somebody has a bad sinusitis and their nose is swollen, they shouldn't be able to smell anything. If they say my sense of smell is fine, then that's probably not a sinus infection. And the other symptom that we see a lot that's diagnosed as quote sinusitis is throat clearing. Okay. They feel like they have all this mucus in their throat, which is, again, that symptom doesn't really have anything to do with a sinus infection. And so, listening to the patient's symptoms and then building a differential on the most likely or least likely things based on their presenting symptoms, I think is the most important thing. Accuracy of diagnosis.
I just had a question for Dr. Holley. We have all these oral decongestants that are available, and patients use those a lot. I know I've discussed with you before, they're not indicated, not helpful. I have used Tylenol Sinus. It helps me with my headache. So please, would you comment on that?
Yeah, and I think the interesting thing about that, we're not having a neurology lecture here. We're having more of an infectious disease. But if you went to the grocery store and you pick up Excedrin sinus and Excedrin migraine and you flip them over, funny enough, they're the same medications. And so, I think that patients, let's say, that the average migraine lasts between 12 and 72 hours. And again, migraine doesn't have to be severe pain. It's pressure, it's fullness, it's pain. It can be unilateral, it can be bilateral, it can be behind the eyes, the forehead, the cheeks. Matter of fact, cutaneous allodynia or pain with touch is a common migraine symptom. And so I think that pushing on people's face to diagnose a sinus infection may actually have a higher sensitivity for migraine than it actually does for a sinus infection. And so much of these over-the-counter medications, the problem is that they treat symptoms universally, regardless of the mechanism or etiology. So, if I put somebody on prednisone, regardless of what was wrong, they're probably going to feel better. And so it diagnostically creates a challenge. And so, for me, I've got a headlight and a nasal speculum. I'm going to look in their nose. I'm looking for pus, particularly under the middle turbinate, because that's where the sinuses are. And you can do that with a otoscope. In an ear speculum, it's a lot harder to see than the tools that I have. But to your point on the oral decongestants, I mean, they took phenylephrine off the market, right? They basically said that it has no clinical utility. I would say that if you look at papers on Mucinex, guaifenesin is a favorite medication for a lot of patients. There was a really good study where they looked at actually mucus viscosity and thickness in patients on a therapeutic dose of guaifenesin, and they saw there was no statistical difference in patients on or off guaifenesin. So I even kind of question the clinical utility of guaifenesin, but if a patient tells me it works, I'll let them do it. I think the risk is low. Afrin nasal spray, oxymetazoline, it's a great medication. It opens up noses. It makes people breathe very well. The main risk is rhinitis medicamentosum or rebound congestion. But if a patient is acutely really stuffy and they want to use Afrin for a day or two, I think, again, we're trying to treat symptoms because that's really what's bothering the patient the most, and reduce the unnecessary use of antibiotics. So again, telling patients there's things to do to make them feel better and not destroy their gut flora or increase MDROs with unnecessary antibiotic prescriptions.
Thank you.
And that's a wonderful transition into our last question. Of the disease that we talked about today, we still generally, our big common binding theme is that most of them are viral, 90+% in a lot of cases, but still carry a really high burden. Like we said, our 20% of our antibiotic use is sinusitis when we know that this is largely a viral disease state. And so consequences of antibiotics are always, I feel like, a difficult thing to talk about because a lot of the consequences are down the road consequences. They're not, it's not like you took too much Coumadin and now you're bleeding. The drug resistance and C. diff and stuff may happen, a month or two down the road, and that patient may not be your patient anymore. And so I think seeing the negative outcomes of antibiotics are often in front of a provider, so they seem a little bit more hypothetical or not common. But from the infectious disease pharmacist side of things, I see the negative outcomes pretty much daily. But I want to hear from both of your perspectives. I'll start with you, Dr. Wani. What are your biggest concerns when it comes to long-term antibiotic use or frequent antibiotic use for like the health of your patients?
Sure. Thank you, Nathan. I think the first and most important point is the antibiotics are completely unnecessary, unneeded, right? So ethically, it's not even appropriate to treat all these infections, which are 90% viral, with antibiotics. That is my biggest concern. And as Dr. Holley alluded, educating our patients about this is really important. And I think in primary care, we take great pride. We talk to our patients, and if we have a relationship with them, most of them do tend to listen to us. So educating them is really important. Then, of course, about the side effects of antibiotics. Antibiotics are not benign things, right? They all have side effects. Every antibiotic, every medication has side effects. And, I mean, we can't even talk about the different side effects of the antibiotics. They are a large number, right? From kidney failure, from, drug rashes, from damage to multiple organs. They can have severe side effects, and we see them in our practice. Also, as you mentioned, C. diff colitis, that is a real thing. And now it has become so common. It is so resistant. Patient get recurrent colitis. So I personally had a patient who was treated with 10 days of antibiotics, and she was only 45, healthy, developed C. diff colitis, and was sick for the next 3, 4, 5 months. So that we have to keep in mind. Also, as you said, we have the penicillin. We love the penicillin. It's such an old antibiotic. There are many new antibiotics coming up, and they're all very, very expensive, right? The cost are enormous. I know you do that a lot in ID when patients have allergies or they need a specific, how many loopholes you have to go through to get them covered by the insurance. So the rising cost of that is another thing. And of course, we are creating super bugs. We just had a COVID run, and we know how hard viral infections can be. And now, with using these antibiotics indiscriminately, we are creating bugs that are resistant, and that will cause more problems in the future. Thank you.
Yeah, I mean, at Carilion, I would say, compared to other large tertiary care institutions, we have maybe kind of an average amount of resistance. I wouldn't say that we're like some other metropolitan areas who, have a really, really high rate of antimicrobial resistance. So I feel like we're in a place where, if we can be good stewards, we can prevent from getting to some of those pretty crazy situations. But, we have documented resistance to every single antibiotic. Thankfully, there's only that I can think of a couple patients where that's ever happened in the same organism. But there is resistance to every antibiotic in our area. And so when they kind of, when the different organisms are able to kind of share some of that information with each other, and when they talk, particularly in the hospital, is when we can have really, really scary situations that happen. But I'll pass it over to Dr. Holley for your thoughts about consequences of antibiotic use.
Yeah, I think for me, I think some of the intangibles that are really starting to show up in the research is looking at the link between the gut and the brain, and really the importance of this gut microbiome in general overall health. And topics such as pediatric obesity, ADHD, depression, anxiety, dementia. And again, we don't have data that shows necessarily causation between antibiotics and these conditions, but we're certainly seeing associations. And I think as more research is done, and there was a good paper that was looking at the gut microbiome of children who had been prescribed antibiotics, and they looked at a lot of different parts of that. And what they showed was after a single course of amoxicillin in some children, the diversity of their gut microbiome was disrupted for up to 2 years. So this is not just a, hey, take your antibiotic, eat some yogurt, and you'll be better in 2 weeks. This has potential long-term ramifications. And for me, who sees these children who are on antibiotic after antibiotic after antibiotic, I really wonder what we're doing long-term. And because nobody's really looked at it from that perspective, I don't think we really know the answer. And so, in any condition that we encounter in medicine where we don't have all the information, I think we have to be a little bit hesitant and more judicious in how we dull out those medications. We've all seen it, the magic medication. I mean, we can look at the fluoroquinolones, right? They were supposed to be awesome. And then, tendinopathy, all these other things. When I first started ENT training, we'd put chronic sinus patients on fluoroquinolone for a month. And with more, data and research, we know that chronic sinusitis is really not a, quote, bacteria problem as much as a chronic inflammatory condition. And we're looking more at interleukins and cytokines and all these other things that lead to chronic inflammation. But I just think we need to be good stewards. We need to think and have shared decision-making conversations with our patients about, it's not just diarrhea. There may be more to this. And when I see a 6-month-old kid that's been on 4 courses of antibiotics, what does that mean down the road?
Yeah, I feel like we're only just scratching the surface from like an evidence standpoint of like the kind of deep relationship that human beings have with their kind of colonized flora and what that means for like development. One of my favorite kind of things that came out of some of the fecal transplant studies that were done early on was where they were using, instead of kind of using these like pooled donors, they were using specific donors for people, and after the recipients of the fecal transplant were having body habitus changes that mimicked the person who donated, in some cases losing or gaining weight to reflect the person who donated. And I just thought that that was absolutely fascinating, and I think that clearly shows that there is more going on with normal flora than just kind of hanging out and helping us digest things. So I think there's still a lot we need to learn about the gut microbiome, and it's kind of interesting when we've been studying stuff for so long to realize how little we know about some things. But I think anything we can do, particularly in pediatrics, I think to preserve normal flora and minimize antibiotic use, like I think it's only has the potential to help people in the future. Um, I really want to thank both of you for this excellent discussion today. I think there's some really great teaching points, and I hope people get some great information from it. For the folks listening, thank you for trying out our podcast series. Please continue to follow our series. Additionally, visit our ambulatory antimicrobial stewardship website at carillionclinic.org / antimicrobial stewardship. You can find treatment guidelines, educational videos, and information on how to contact our antimicrobial stewardship team for patient care questions. Thank both of you again, and I would love to have you back on in the future to talk about more stuff.
Thanks,
Thank
Nathan.
you, Nathan. Thank you.